Thank you, Dr. Verma and the organizing team for inviting me. I went to school in Lucknow, so it's homecoming, and I appreciate the opportunity. Uh, my work has been made easy today by the previous speakers, so I'm going to go a little fast. Also, I noticed that there's a timer, so I have to beat that timer. I don't want to lose that battle. So the presentation that I put together is to give you a snapshot in my life, in my working life, in my professional life, not my private life. I work as a surgical pathologist with a lot of lung specimens, cytopathology and molecular pathology, and this is my presentation that I've done. So these are my aims for today: review the currently actionable driver mutations in non-small cell lung cancer, discuss some issues with lung biomarker testing, discuss what testing is currently available, and discuss future testing of lung carcinoma. A lot of these topics have been covered by my previous speakers over here who have gone into great details. So I'm going to go a little fast with some of those slides. This is a very interesting case that came across my table a few months ago. This was a young 42-year-old female. She was a hematologist by profession, and she was diagnosed. She was having symptoms of dyspnea. She went on to have a CT scan, found to have multiple lung lesions. She went an endobronchial resection of one of these lesions, and it was good chunks of tissue that came across. And this is what it looked like at low power. This was a well circumscribed lesion. At low power, it looked like a lot of epithelioid looking cells. These looked like had a mild to moderate pleomorphism. The background looked like had some mucinous. So I thought that, okay, this is another case of lung adenocarcinoma, which is the commonest malignancy that I see in my practice. So I ordered my usual stains and biomarkers, and they were all negative. So I started looking hard. I found that there were some areas that looked very spindle, which I had not noticed earlier. So it looked like it had a biphasic morphology. So I added more stains to it. Again, those were negative. I added a third round of immunostains. Those were also mostly negative. So I'm going to show the ones that came up as positive. So AE1, A3, a cytokeratin, was diffusely positive. Mammoglobin was positive in about 20-25% of the tumor cells. S100 was positive in about 60 to 70% of the tumor cells. GATA3, which is a nuclear immunohistochemical stain, was positive in the tumor cells. This patient did not have any history of breast cancer, and there was no abnormality on the CT scan of the breast. So the specimen was also submitted for NGS testing, as is done reflexly at our place. And this particular mutation was picked up, ETV6 MET fusion. Diagnosis: secretory carcinoma with ETV6 MET fusion arising from minor salivary glands of the bronchus. The first cancer that I have seen in this setting. I've seen a few secretory carcinomas, but never from the lung before. And this had a very unique fusion gene partner. And why is this important? Because there is a targetable, this is an actionable target, and there is a drug that is known to cause or is used for management. And this is the reference to that paper which was published a few years back. So I wanted to bring this case because I wanted to highlight that how much we have come along in terms of lung biomarker testing. About 10-12 years ago, when I started testing for lung biomarker, we were thinking about EGFR, then came along ALK, ROS1, PD-L1, and then we moved on from the platform of RT-PCR to NGS testing, and that expanded. So this case just highlights that now, where we come across, what are the things that we are finding on these testing, and it's very interesting. This slide was presented earlier also, and just shows the complexity of lung cancer, that lung cancer is a very complex tumor, and it shows a high tumor mutational burden. Histological subtyping, this is the basis of pathology, molecular pathology and medicine. We start everything with histological subtyping. So the major subtypes, is non-small cell carcinoma and small cell lung carcinoma. About 15-20 years back, this is the only thing that the clinicians wanted to hear from us. Is it small cell or is it non-small cell? And then the treatment was decided. But now we know that we've come across a long distance, and it is very different now. So the major subtypes, adenocarcinoma is the commonest type, followed by squamous cell, large cell lung carcinoma. Less common types is typical carcinoid, atypical, large cell neuroendocrine, small cell. Correct histological typing is very, very important. That is the basis of all of disease management. So we rely heavily, and I use morphology along with immunohistochemistry in a good number of my cases, along with molecular testing to correctly classify this. Now, what is biomarker testing? This is a way to look for genes, proteins, and other substances called biomarkers that can give information about tumor. Companion diagnostic test, you might have heard this term being used earlier, is paired with a specific treatment, like T790M EGFR mutation is paired with osimertinib, which is the preferred treatment option for this. So now the big question comes that why do we do lung biomarker testing or biomarker testing? So this graph shows that there's three lines over here, and they show that the patients who receive targeted therapy, they perform much better than those that did not get a targeted therapy as compared to those patients who did not have any underlying driver mutation. So this is very important, that those patients who have a targeted an actionable biomarker and are treated with a targetable therapy respond very favorably. Targeted therapy, again, has been talked about by my previous speakers over here. These are drugs or substances that block the growth and spread of cancer by interfering with specific molecules, which are referred to as biomarkers, and they're involved in the growth, progression, and spread of cancer. There's some other terms that are used for targeted therapy, including personalized medicine, precision medicine, molecularly targeted therapies. I like the term personalized medicine. Oh, sorry. So moving back to the genetic abnormalities that we see in adenocarcinoma, so I'm going to start with adenocarcinoma, which is the commonest subtype. And this table highlights that, in about 70 to 75% of lung adenocarcinomas, we are able to find the underlying driver mutation. KRAS mutation in our scenario is the commonest mutation. 35 to 40% of lung adenocarcinomas is associated with KRAS mutation, out of which G12C is the commonest subtype. It was very interesting. Somebody was presenting the data from I think Tata Memorial, and they said that here it is EGFR mutation, which is the commonest subtype. However, the scenario is a little different. In our setting, followed by EGFR, which is seen in about 10 to 15%, followed by ALK, ROS, BRAF, and others. So this is a list of the known actionable or non-actionable biomarkers in lung adenocarcinoma, some of which I just went about: KRAS, EGFR, ALK, ROS1, NTRK, and so on. The next two slides talk about these biomarkers and the targeted therapy that exists today. And this is a very evolving field. Every few months, we hear about a new drug that has come on in the market. We are moving on from first generation to second generation to third generation drugs. Just to clarify that, when we are doing biomarker testing, especially somatic tumor testing, we look out for two types of mutations: the driver mutations, which cause the cancer, and resistance mutation, which is seen when these patients are treated with the TKI and there is relapse or recurrence of the tumor. So that is known as resistance mutations. And these are different mutations. Sometimes these mutations can coexist. So initially, when you're reflexly testing the patient specimen, you can find the driver mutation and the resistance mutation at the same time. Why is it important to understand the pathobiology of tumor? Specific drugs that can target these mutations, it's important, because then only these drugs can be given. And testing for both is recommended. Good example of that is EGFR T790M mutation. Immunotherapy has become very important in the last decade. Immunotherapy, and specifically PD-L1 testing. Somebody showed a case of melanoma that was, I think, one of the first cases treated with immunotherapy, and that patient responded very well, and then relapsed after a few months. We test for PD-L1 very routinely in our setting for lung carcinoma specimens. The other immunotherapies that are known and exist is T-cell transfer therapy, monoclonal antibodies, treatment vaccines like BCG, which is used for bladder cancer, and immune system modulators. Now, PD-L1 testing in non-small cell lung carcinoma is done using immunohistochemistry, and the scoring system that is used is the TPS. So there's two systems that exist, the TPS and the CPS. So in lung carcinoma, we use the tumor proportion scoring system. Going to go through the important mutations that I see in my practice, and what is some of the important clinical features with it. EGFR, epidermal growth factor receptor, is present on the cell surface and helps cells to grow and divide. Non-small cell lung cancers have too much of EGFR, which helps them grow faster. And there are several drugs that exist in the market: first generation TKIs that target EGFR, second generation, and third generation. Third generation TKIs can target both driver mutations as well as resistance mutations like T790M. This cartoon shows you a picture of the EGFR receptor and some of the downstream signaling pathway that is associated with EGFR. EGFR mutation is in our setting is seen in about 10 to 12% of patients. The patients are usually female, they're non-smokers, they're young, and they're usually presenting at an advanced stage. In South Asia, places like Taiwan and Korea, the incidence of EGFR mutation is found to be even higher in the range of 50 to 60%. Most of these patients who have EGFR mutations and are treated with TKIs land up with resistance or relapse in a very short period of time. The commonest resistance mutation that we see is T790M. Amplification of the MET oncogene and mutations of the PIK3CA are other mechanisms of resistance mutation. This cartoon highlights the driver mutations and the resistance mutations that are associated with EGFR. The testing methodologies is NGS, which has become very available in our setting and very commonly used. Earlier, we used to do RT-PCR. Now we moved to NGS testing. Sorry. This again highlights the fact that what is the advantage of treating these patients with targeted therapy. You can see that there's a very definite, progression-free survival of patient, who was treated with the second generation TKI. ALK rearrangement, this is the second commonest, actually is the third commonest mutation that we see in our practice. 2 to 5% of all non-small cell lung carcinoma patients have ALK gene. EML4 ALK is the commonest rearrangement. And what happens is that there's a small inversion within chromosome 2p, leads to fusion gene aberrant expression of ALK and constitutive activation of ALK tyrosine kinase, meaning thereby there's too much of ALK. And it affects the further downstream signaling pathways, leading to uncontrolled proliferation and survival of cancer cells. This cartoon again highlights what happens in chromosome 2, this rearrangement and some of the downstream signaling pathways. People who are treated with the ALK TKIs are again, known to relapse and can have a tumor. And when they relapse, this is the two forms of mechanism that can happen: ALK dependent and ALK independent. And this is more of an esoteric testing. We don't do this ALK resistance mutation testing at our place, but it is available in some labs because there are known drugs that are known to target specific, resistance mutations. So again, as I just talked about, that we don't do these ALK resistance mutation testing in-house, but is available. And if the clinicians request, then it can be sent to those testing. And resistance testing is still experimental. Vision is for circulating tumor DNA testing. So using a single platform to test for all mutations, whether it's driver or resistance mutations. ROS1 mutation is the other common mutation that we see in our setting. 1 to 2% of all lung adenocarcinomas have ROS1 rearrangement, and 14 different ROS1 fusion genes have been reported in lung cancer, and the commonest is CD34 ROS1. Patients are again usually young, never smokers, and have a diagnosis of adenocarcinoma. Crizotinib, which is a drug that is used for ALK rearranged adenocarcinoma, is also used as a treatment modality for ROS1 rearranged adenocarcinomas. And this is a waterfall curve which just shows that anything beneath the line means it's good. So the green line means that the patients had a partial response, whereas the ones with the purple had a complete response. So anything beneath the line means, so this is a waterfall curve of that. BRAF mutations is seen in about 2 to 4% of lung adenocarcinomas. Most common is V600E. This is the same mutation that is seen in many other tumors, including papillary thyroid carcinoma. Now, there are specific drugs that are known to target this. RET rearrangement is seen in about 1 to 2% of non-small, and there's specific drugs called elpercatinib and pralsetinib. I have a hard time trying to pronounce these. Other tumors with or other biomarkers that have targetable drugs associated with them is MET exon 14 skipping and NTRK. Things to know about MET exon 14 skipping is that it can be seen in both squamous and non-squamous non-small cell lung carcinomas, and 20% of sarcomatoid lung carcinomas are known to harbor MET exon 14 skipping. NRG fusion, it can be seen along with KRAS mutation and is found with highest percentage in invasive mucinous adenocarcinomas. They respond to pan-HER inhibitor afatinib. Tumor mutational burden, when we are using the NGS, we'll also look at the tumor mutational burden that looks at the number of genetic changes in the cancer, and it is primarily done to see if immune checkpoint inhibitors will work. Liquid biopsy, it has been covered by many previous speakers. So, it looks at fragments of tumor or cells in blood, and it can be used for diagnosis, looking for treatment response and resistance testing. Some places do both somatic tissue testing as well as liquid biopsy at the same time. At our place, we don't do it at the same time, but we do it when the patient comes up with a recurrence or relapse. So these are some of the important clinical scenarios that when should we test for biomarkers. So at our place, we test it reflexly at the time of initial diagnosis. The specimens can be histology or cytology. We don't differentiate. Most of the specimens that we test are cytology specimens because we get a lot of EBUS, EUS, FNAs. So we test all of them. And that's used not only for diagnosis, but also for molecular testing. A resection if the testing has not been done earlier, and recurrence to specifically look out for resistance mutations. What specimens are good? Biopsy, resection, cytology specimens, liquid blood. Our experience with cytology specimens is extremely good. How do we test for biomarker? The platforms that we use is immunohistochemistry, FISH, NGS, RT-PCR, and digital droplet PCR. How do we report it? We have we follow the standardized CAP reporting format for reporting all these biomarkers that is available free at the CAP website. Questions that I thought that will be interesting, so which lung cancers cases to test for biomarker? So, we test all non-small cell lung cancers, whether it's adeno or large cell or NOS, we test all of them. This is an important scenario that, that I come across, that should neuroendocrine tumors be tested. At our place, we test large cell neuroendocrine carcinomas routinely for biomarker testing, and small cell lung carcinomas in specific scenarios if the patient is young, Asian, female, and a never smoker. When should I repeat biomarker test? This is, still up in the air. But if the initial testing is negative, then I don't think twice about repeating the testing. What samples, as I just mentioned, cytology, histology, liquid, blood, all of it is good for biomarker testing. How many tumor cells are needed? So good answer is 100 tumor cells. That's easy to remember. If you have 100 good viable tumor cells, that's very good for biomarker testing. Multiple tumors, sometimes we land up with resection specimens that have multiple tumors. So what should be, again, this is not set in stone that what should be done. So the paradigm or the dictum is that you definitely test the most dominant tumor, and then we wait for the clinicians if they think that this is intrapulmonary met or a synchronous primary tumor. Then sometimes we will go ahead and test the other tumors. Who should be ordering the test? This was a question that was asked a few years back, and whether the clinician should be ordering it or whether the pathologist. At our place, it is the pathologist who takes the onus, and we order it reflexly. Repeat testing for things like T790M and mutation testing should be kept in mind. So summary, knowledge around molecular drivers in non-small cell lung carcinoma and lung carcinoma in general is exploding. New therapies are being approved every year, and we are beyond what can be done with single analyte testing. So, the aim is to move on to a platform like NGS, which can look at multiple, biomarkers at the same time. And next generation sequencing platforms testing will not only test mutations, but translocations, amplifications, copy numbers, and others. Thank you very much for your time.